Okay, assalamu alaikum everyone. Welcome to the psychological aspects related to GIT revision and hopefully simplification. My name is Shurooq Elshaeir and I'm from batch 2028. I'm going to try my best to make this as concise as possible, focusing on where questions may come from, depending on the pattern that I've personally seen, and hopefully simplifying things like criteria and certain aspects of this PowerPoint. So basically, this lecture involved 3 topics: obesity, colon cancer, and GERD. And just based on bulk, I'm going to start with obesity first. So obesity obviously is a condition marked by excess accumulation of body fat. And as we all know, obesity can be genetic, but it also has a very important behavioral aspect. And as we see it now, its prevalence in our societies, especially even in children, is increasing. Because it all starts from there. It all starts in childhood when food is given to us as a reward for good behavior. And usually it isn't healthy food. It's candy, it's fast food. And that pattern keeps and stays with the child. That could be one type of behavior that carries on. Another thing is if the family's habits itself are not really the best, whether it's eating large quantities of food or eating not nutrient rich food, and then not exercising or doing in moderation, for that also stays with the child as they grow up, and it can lead them to a pattern of obesity. So, and obesity, I think this piece of information is one of those niche pieces that could be asked about right here, which is that it is very preventable, and some researchers believe that obesity is second only to smoking as preventable cause of death. So obesity in childhood, that's what I just mentioned right now, how it develops as a habit, how it's given as a reward in children, and that's where it starts. Now, obesity is accompanied by a bunch of psychological issues, whether it's depression, whether it's anxiety, yada, yada, yada. And we took these across the years, but this part, it focuses mainly on social anxiety. So like any other psychological issues, we have our trusty DSM-5 criteria, which is sometimes a bit annoying, but inshallah, I found a way to make it easier. So we have 6 criterions right here, but you can group them in a way to remember them. So criteria A, you can remember it as the most important thing, and it is marked fear or anxiety about one or more social situations. We're talking about social anxiety. So it makes sense that the number 1 criteria, or criteria letter A, shows that there is marked fear or anxiety about one or more social situations. And what are they concerned about? Scrutiny. So the first thing that they're thinking about is, I'm scared of social situation X because I'm afraid I'm going to be made fun of. And in criteria related to social anxiety, when we're talking about children, it is very important to see how they behave with their peers, because culturally they could be masking and just pushing themselves to act the way that adults want to see them act. So to accurately be able to diagnose this criteria in a child, you have to see it in a peer setting. So in criteria A, they have fear of a social situation where they might be made fun of. Like, for example, kids in school, they could be scared of bullying, so they wouldn't want to speak up in class or make a presentation, for example. Moving on to criteria B. So other than the fact that they're scared of social situations where they might be made fun of, they also want to avoid that in any way, shape, or form, so they become people pleasers. So they will act in a way or show anxiety symptoms that they fear that they're going to be acting in a way where they won't be perceived in a positive way. So they will start acting in a way where they think it will be acceptable and try to fit in as much as possible. So they show fear of acting in a way where people don't like them, so they think they're already at a disadvantage of some sort. Criteria C is that any social situation provoke fear and anxiety. You're going to start to see that the criteria are going to start to match each other, which is where you can start to group them. So as we said, criteria A, they have marked fear of or anxiety of a specific social situation or more where they might be made fun of. And to avoid that even more, they show fear of that they may show a specific behavior that they have that won't be accepted by others, further isolating them away from their peers. And then C, they're scared of social situations, and that provokes a reaction from them. And in kids, it can be seen as anxiety, crying, tantrums, refusing to speak in social situations, and more. D is that this fear or anxiety, or if there's a reaction of some sort, is blown out of proportion for the threat at hand. okay? And then E, you can think of as the timeline. So all of this should be happening with the person for 6 months or more, okay? And then the fear, anxiety, or avoidance causes clinically significant distress or failure of functioning. So to group them again one more time, A is they have a marked fear or anxiety about one or more social situation where they're going to be made fun of. B is they fear that they may show a specific behavior that will get them further like kind of like disapproved or isolated from society, or it won't cater to their peers' idea of them. C is that they have fear or anxiety whenever they see that they're going to be put in a social situation. D, that may and that fear and anxiety is blown out of proportion. And also, the C, sorry, I skipped C. C is when they show a reaction to that social situation. And then E, all of that needs to happen within 6 months. And obviously, as you can see, we keep repeating that they're scared, they're eliciting a reaction, they're scared of not being accepted. So it gets to a point where F, they stop functioning and becoming a functional member of society. G, H, and I are what I like to call the exclusion criteria of any DSM. Almost in every DSM criteria that I've seen, there's always one or two where they have to make sure that this behavior is not coming from anything else. For like what? Like this behavior is not attributable to a drug abuse, or that they're taking a specific medication, or that it's related to another psychological issue like panic disorder or body dysmorphic disorder. And if that they have another medical condition present, then it has nothing to do with what's happening. So G, H, and I are kind of like the exclusion criteria. So I have a child that is scared to speak up in social situations. You can clearly see they're in distress when that happens. They're people pleasers. They want to be accepted by anyone. They have marked fear of one or more situations. And then I know that this child isn't sick. They're not abusing any drugs. They don't have any other physical issues. So this is pure social anxiety. It's not stemming from something else. So a mnemonic that you can remember these by, I wish I was, this creative that I made it, but this was done by AI, but nonetheless, it's still helpful. And you can remember it by faces, pain. So like, it's kind of like 2 words a bit. Faces, pain, okay? So F, fear or anxiety. So you have criteria A, they have marked fear or anxiety of one or more social situations where they might be made fun of. A is they act in a way, and that's criteria B. So they act in a way, or they fear of acting in a way that it won't be accepted by other people, or they'll be negatively evaluated. So you can think of this criteria is that they low-key turn into people pleasers so that people don't have a reason to not like them. C, children's reactions. So these situations that they're scared of are starting to elicit a reaction, and in children it's crying, it's throwing a tantrum, it's freezing, for example. E, excessive fear. This fear is blown out of proportion. And S, 6 months. All of this needs to happen for 6 months or more. P, proportional impairment. And you can think that it causes significant distress or impairment of functioning. So P, you can think of that they're stopped, they're no longer functioning in society. A is attributable to, and you can see A, I, and N are related to G, H, and I, which are the exclusion criteria of the DSM-5. So A, it's not attributable to any substance or drug abuse. I, it's independent of other disorders, like other psychiatric disorders. And N, it is not related to any other medical condition if it is present. So the fear has nothing to do with it. It may take a bit of time and for your brain to organize it in a way where you can digest it, but I feel like this is going to be, inshallah, an easier way than just trying to remember each criteria. And the more you group them in your head, the easier, inshallah, it will be remembered. So what do we do with people who have social anxiety? Well, there are a couple of options. Psychoeducation, and this usually actually works best with psychiatric issues where you can't really do anything and the patient maybe doesn't even believe in, you can't really sit with them for an hour and talk, right? So you can educate them about the subject. You can counsel the family members, and this is actually very important, especially if it's with children, so that they know how to support their kid and not further turn their issue into a more traumatic behavior, for example, or more traumatic pattern. And then behavioral therapy, how to deal with it. I guess that's it about obesity. It's, as I said, it's the biggest chunk. So yeah, moving on to the next biggest chunk, which is the bulimia nervosa. Okay, so bulimia nervosa is characterized by a couple of things. It's characterized, first of all, by binge eating. So they have a period of time where they lose control and they eat like an amount of food that is larger than normal, and they always feel like they're in lack of control. But what happens after this episode of binge eating is that they try to compensate for it, whether it's extreme exercise, taking laxatives, or as we know it, like bulimia is infamously known for purging or throwing up what they ate. Okay? Now, the binge eating and appropriate compensatory behaviors both occur in average at least once a week for 3 months. Once a week for 3 months. So there's your timeline. Self-evaluation is under the influence by body shape and weight. Like, this is, I think it's comparing it to anorexia nervosa, which I'm going to talk about here. Anorexia, we used to say, and you'll know them just by looking at them because they're incredibly thin. This one is not tied to body shape or body weight. They could look completely normal on the outside. And the binging or purging does not occur exclusively during the episodes of behavior. That would be common in those with anorexia nervosa. So this happens after the episode of behavior. And I guess I understand why they paired it with gastroesophageal reflux, because if someone's making themselves vomit over and over again, then obviously they're going to start eroding their esophagus, okay? Now, being that she mentioned the DSM criteria for anorexia nervosa again, I just wanted to go through all of them and give you a brief idea of the difference. So body image disorder is when someone is perceiving themselves in a way that is not true. And this is not related to body weight. I remember this very clearly from last semester. Body image disorder, one of its exclusion criteria is that their issue is not with their body weight. It's like more of a feature that they have, okay? Anorexia nervosa, anorexia in general, you can think of it as restriction. This person has a fear of gaining weight and they're not eating. And if they are eating, it's happening in two ways. They're restricting their food, or they're restricting and throwing it up. So that's anorexia, the purging type. Bulimia, actually, let's go to binge eating disorder. Binge eating disorder is characterized by recurrent episodes of binge eating where they lose control and they eat large amounts of food in a specific amount of time. But what makes a difference from bulimia nervosa is that there is no compensation here. They don't throw up, they don't take laxatives, they don't exercise a lot, they just feel guilty about it and they don't know what to do. In bulimia, there is compensation. So body image disorder is related to a feature, not body weight, and they're perceiving it in a way that's not true. Anorexia nervosa is restricting, and when there's purging, there's restricting and throwing up what they do eat. Bulimia nervosa is binge eating and compensation. Binge eating disorder is just binge eating, okay? So I'd say read this, because if she mentioned it, that maybe she would want to get questions about the eating disorders, maybe it confuses a bit, okay? Now with the last part, we'll talk about colon cancer. She started with a very general information about fight or flight. We all know this, fight or flight. If you see a bear, what are you going to do? You're going to flight. You're obviously not going to fight. Adrenaline is released, and it has a bunch of effects on the body, because again, it's giving you the energy and the things that you need to run away from a threat. But when this fight or flight response is elicited for other reasons, that can be an issue. And generally, or you can kind of like understand it through the general adaptation syndrome, or GAS. So GAS described this in 3 stages. The alarm stage. Alarm, I have a threat. So this is where the threat starts, whether it's a bear or an exam or whatever, okay? And the fight or flight starts, hormones start pumping in your body, you have a higher heart rate, blah, 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 blah. Resistance is when this starts to persist. So the body's defenses, first of all, start to become weaker, because they're starting to allocate energy to keep you going against the threat. Because obviously this person is perceiving the threat way bigger than it is. So the body is now it's not focusing on its main things. Fight or flight is generally an acute response. When it starts to become chronic, that's an issue. And it can lead to the 3rd stage, which is exhaustion. The body starts to loosen its ability to combat, and the person's just burnt out. And here is where they might self-isolate, they start to get depressed, maybe develop anxiety. So this is what the general adaptation syndrome shows. But very important to remember that this model has limitations, and its biggest limitation is that it does not consider the psychological and cognitive factors. It only considers the physiological response, okay? Another model is the biopsychosocial model, which I think we went through many times. You have biological factors that lead to disease. A disease may socially affect you. The social effect can psychologically affect you, yada, yada, yada. Now, in general, stress, let's go here. Stress does not go well with our body's physiology, especially if it's chronic. And lots of research that she talked about suggests that stress is now, it may be causing people to develop cancer in a way, basically because once you're stressed and you're under this fight or flight for a long time, your body's defenses slow down. You may be prone to more of infections. You may, because like your immune system is decreased than normal, right? And physiologically, your body's just trying to focus on this threat that it's neglecting all of its other physiological attributes, and that can lead to errors, which can lead to cancer. And طبعا the stress can come from many things, like traumatic life events, like or losses, and the weird part is personality. So this is pretty interesting. So type C personality is an introvert that has high neuroticism. So someone who is suffering in silence. If you've read the notes, I think you're starting to realize who wrote them. So they suffer in silence. Whatever stress they're going to, they keep it internal. And other than that, they neglect that and they try to become people pleasers for other people. So they have two major characteristics: restricted affectivity and submissiveness. Restricted affectivity is repression and suppression of negative emotions. So they suppress their emotions, particularly anger, which is not good. The doctor once said that anger or anger outbursts actually increase your risk of developing a heart attack within the 2 hours that you've had it. So that's not good. Low awareness of emotions experience. So they don't have emotional intelligence, or maybe they don't even believe in it. An inability to identify, name, and express them. Anhedonia, we took this before. Passiveness and helplessness in the face of adversities. Restricted affectivity. They don't care about their emotions. They pile it up. They shove it down, and they don't want to talk about it. Submissiveness, pathological agreeableness, compliance, kindness towards others, uncritical adjustment to them. So not only like helping others is an amazing thing, obviously, but when it starts to affect you, like يعني زي ما احنا بنقولها بتيجي على نفسك عشان تساعد الناس, you are compensating on your end to help people, that's when it starts to become sort of even harmful for you. So they restrict their emotions, bottle it up, and then they're also submissive to other people, and they become people pleasers. So technically the perfect personality type is type B. They have equal introversion and extroversion and a low amount of neuroticism. Okay? Okay. So what to do with dealing with this kind of like chronic fight or flight? There's a bunch of things that we can do. CBT is always the number one, but sometimes people don't believe in it, I guess. So you can go through psychoeducation. Yeah, see? Psychoeducation is particularly useful. CBT is actually number one for another thing that I'm going to go through. But yeah, so psychoeducation, the impact and awareness and knowledge about the psychological impact of cancer can really help. And even having like a psychologist and a psychiatrist on the psycho-oncology team is very important. Has actually shown improvement for patients. Behavior therapy, relaxation therapy, very important, especially if the disease that they have is physically taxing. Social support group for the caregiver and family therapy. There is a burden طبعا on them. And it's very important for them together to kind of get through this. And CBT is always almost a given in any psychological issue. Almost, not always. I skipped, the treatment for bulimia nervosa. Unless the patient doesn't want, this is the number one first-line treatment for bulimia nervosa. It is 16 to 20 sessions. Here's the thing about CBT, it's a bit general. If CBT doesn't work, then we go to IPT, which is interpersonal therapy. This one dives deep into the issues. Goes into traumatic issues since childhood, traumatic patterns from parents, and it starts to address it at the root, right? It's divided in 3 phases: raising awareness, addressing and resolving the client's interpersonal conflict, and discussing impending termination, of the toxic pattern, exploring ways the client can address interpersonal difficulties in the future. So kind of like a way for this to not repeat itself, and then the client and the patient can kind of help themselves as they go on. Okay? So CBT is a bit general. Please do read this. I'm just giving you the general idea. And IPT is more specific. Okay. Exposure with response prevention. This form of treatment was originally based on the anxiety reduction model. Very important. Any models are very important to remember. And this model has obviously evolved over the years. And exposure therapy in general is built on finding the triggers of the person, and then in a controlled environment, helping them once they see the trigger, not to repeat the inappropriate behavior or harmful behavior. Okay, I believe that is all. This is just like a quick way of remembering the information, hopefully simplifying it. Thank you so much for watching. I hope this helped.